Good day, everyone. I am Dr. Summer Emmanuel R. Pilapil-Amante, and I am here today to discuss the part 2 of the surgery of the abdomen as prepared by Dr. Jessalyn Constante. We start with the correction of the left displaced abomasum, and we have the list of risk factors here. First, we have the high body condition score during parturition, and this will have an effect on the gut motility. Next is the high concentrate feed intake and low fiber diet. We were taught in our early college years that the correct way of feeding ruminants would have a ratio of 60-40, 60 on the forage part and 40 on the concentrate part, and at most it can be extended to 70 to 30% ratio. Although a colleague shared to me who worked in the Middle East region that since they are a rich country, they have access to high concentrate feed allocation and really low fiber allocation. So they are feeding the ruminants there, the cattle there, as much as 100% concentrates. That's why on a daily basis, they really have cases of left displaced abomasums. And going forward, we also have a risk factor in the sudden change of feed. And we know that cows are creatures of habit and also their rumen microflora. So any disruption or change in the diet will be detrimental to the animal, and one of the possible causes is the left displaced abomasum. Due to immense pressure also during labor and parturition, the abdominal contents may be rearranged. And we also have the list of associated diseases here. Fatty liver, hypocalcemia, and ketosis are related to nutrition. Then we have metritis and mastitis. The goals to treat LDA include replacement of the abomasum to the proper position, which is at the middle and leaning to the right side. So since recurrence is likely, there has to be a permanent attachment to keep it in the proper position. Metabolic status should be corrected and maintained and treat other concurrent diseases. To help you decide what better to do, it would be wise to identify the value of the animal such that if the cow belongs to the upper 25% of the herd, it would be good to cut them or operate on them. If she belongs to the middle 50%, it would be good to tuck him or do the toggle method. And the lower 25% would be better to be culled instead. There are two ways to treat left displaced abomasum. The first is the conservative technique. In doing this, which is just rolling the animal back and forth, the cow will be cast on the right side and turn to the left while performing the ballotment. Then she will be in dorsal recumbency and turn left and right as if shaking the abomasum to place. The cow will then be rolled into left lateral recumbency and remain in that position for 5 minutes. The second approach is the surgical technique, which can be further categorized to open and closed or blind. The techniques listed in this slide belong to the open surgical approach, although letter C can also be done blindly with the use of a towel. Here's a flow chart of the different surgical methods to correct LDA. In the left or right flank, omentopexy, left flank abomasopexy, and percutaneous fixation, the cow will be in a standing position as the incisions are just on the side of the animal. The paramedian approach will require the cattle to be in dorsal recumbency as the incision will be at the caudolateral side of the abdomen of the animal. Let's review some relevant anatomy. The normal position of the abomasum is at the middle, below the abomasum, and extending towards the right side. For a displaced abomasum, picture A is showing us the rear view of the LDA being the X in the picture. And picture B is showing us the left lateral view of the abdomen where the X is the abomasum that has been displaced. This is just another picture of the left lateral view of the abdomen with a displaced abomasum. And let's try to watch this video. To correct LDA, we can do the right paramedian omentopexy or abomasopexy, which involves a laparotomy. Another surgical way is the Utrecht method, where the cattle will be in a standing position and incised in the left flank. The landmarks are the last rib and the transverse processes of the lumbar vertebrae. In giving the anesthesia, you would have the same landmarks in doing the inverted L and paravertebral regional nerve blocks. So those are the two approaches that you can do. In most cases, the abomasum appears directly in the laparotomy room. In doing the percutaneous fixation, the technique is to grasp a fold of the greater omentum on the 11th to 12th rib and pull into the laparotomy wound. Expel gas if necessary. Pass a 1.5 meter long non-absorbable suture material with a 8 centimeter straight triangular needle at both ends on the folds. Care must be taken to avoid blood vessels. Push the abdomen ventral to the ruminal antrum into its normal position. Take the needles along the left abdominal wall separately, shielded by the hand so that it will not puncture any other contents inside, and insert through the ventral midline. And that is about 10 to 15 centimeters cranial to the umbilicus. Picture B shows us the pointed part on the ventral abdomen near the location of the forceps, which is where the needle is pointing inside. Once part of the needle has already appeared externally, it can be pulled out with the forceps. The mastress suture is drawn tightly and tied on the outside of the body by an assistant. The laparotomy wound is closed as described for the left flank laparotomy. For the post-op management, parenteral antibiotics are given for 3 days. Less concentrates will be given and more fiber will be offered. And the fixation and skin sutures are to be removed in 10 to 14 days post-operatively. Next, we go to percutaneous abomasopexy using a bar suture. And we call this the toggle or bar suture. The position will be at the right lateral recumbency and the animal will be sedated using xylosine. Same as in the rolling technique, the cow will be cast on the right side and pull in dorsal recumbency. To determine the site of the abomasum, a combination of percussion and auscultation will be done between the umbilicus and the xiphoid. A characteristic ping sound will be observed on the right side of the ventral midline. Insert a 4 millimeter diameter choker cannula through the abdominal wall at the right side of the ventral midline near the xiphoid. And these are the materials for the toggle method. And I actually have the same equipment right here. And the brand name for this one is Jorvet. So in each pack, you already have the 2 sutures, like this one, okay? And then I have here the bar, and this is the cannula, and this is now your choker, okay, that you would insert it inside, okay? This is another type of the toggle technique. Note that the bar sutures have the red bar on one end while the other one is free. The difference between the Jorvert brand is that it has this bar, so it will be easier to hold the cannula in place while puncturing on the right side of the ventral midline. To demonstrate how to use it, you will be inserting this bar suture inside the cannula, and it will be pushed by the trocar, okay, until the bar suture will be out the cannula. And you will remove your trocar, okay, and also your cannula so that the bar suture will be left inside the ventral midline of the cattle. Observe the location of the disinfection area, which is at the right side of the ventral midline of the cow. The trocar cannula will be inserted, and this will expel gas and acidic gastric fluid. Then the bar suture will be placed in the cannula in this manner and pushed by the trocar to the abomasal lumen. Remove the cannula and trocar and leave the suture in place. Place a second suture about 7 centimeters from the first. And then after which, you're going to tie the free ends of the two sutures together. Note that the bars of the suture are now in the flat position beside the abdominal wall, and this will hold the attached abdominal content in place. Further expel abomasal gas before removal of the cannula of the second suture. After tying, roll the cow into left lateral recumbency and allow her to stand. Same pose of management will be done, and the bar sutures will be cut after 10 days. In conclusion, abdominal surgeries are warranted, especially in emergency cases. The special surgical instruments such as the toggle kit and the straight triangular needle may be necessary to accomplish the surgery. Knowledge of anatomy and proper physical examination are important because some procedures are done blindly, such as the toggle method. Most abdominal surgical procedures can be performed in standing position, either in the left or on the right flank. Reliable assistant surgeons and proper physical restraint are important in order to perform the abdominal surgeries. Next, I will discuss the correction of the right displaced abomasum. Conservative approach on the treatment of RDA includes ample exercise and increased forage allocation, which can be attained with better access to pasture and metoclopramide and calcium borogluconate administration to promote gut motility and tone. Classical signs of RDA pertain to volvulus, wherein pain and bruxism, tachycardia, and rumen stasis can be observed. Rectal palpation should be done to examine the abdomen. Lastly, metabolic status would reveal alkalosis in the early stage, then changes to acidosis toward the late stage of the disorder. Displacement always starts with a flexio, or displacement about a horizontal axis running pagiocaudally. In many cases, the flexio is followed by a rotation wherein the abomasum turns about an axis perpendicular to its greater curvature. The first type of displacement is that the greater curvature of the abomasal corpus moves dorsally along the right abdominal wall. The other type is that the pyloric moves cranially along the right abdominal wall. To correct it, a right flank laparotomy will be done with the incision located 1 handbreadth behind the last rib. The abdomen will be exposed and explored, first to determine the type of displacement and to detect any possible complications. The pylorus will be grasped and brought out of the incision. The abomasum may be punctured before repositioning to expel gas. If a flexio is present, it will be corrected by pushing with the whole lower arm the greater curvature in a cranioventral direction along the right abdominal wall. If a flexio with rotation is present, the abomasal corpus is pushed first in a cranial and ventral direction, then the pyloric part is grasped and pulled caudally, meaning it will be like stretched out along the right abdominal wall. This picture shows us a simple right-sided displacement wherein the abomasum moved proximally, now having its majority at the right abdominal wall. As this is a flexio, it can be corrected by pushing with the whole lower arm the greater curvature in a cranioventral direction along the right abdominal wall. This picture shows us a flexio with a rotation and the direction of the manual connection. This picture shows us another flexio with a rotation and the direction of the manual correction. Note that the pylorus is already located cranially. To prevent recurrence, a fold of the greater omentum, about 20 centimeters caudal to the pylorus, this is the pylorus, is incorporated into the first layer of the abdominal wall closure. Closing the layers is the same as that of the right flank laparotomy procedure. It is important to maintain a good metabolic status for the animal by giving fluid therapy of at least 10 bottles of 1 liter normal saline solution with dextrose or LRS. Now we proceed to cecotomy. Clinical signs of cecal disorders or torsions are similar to RDA, which is also like volvulus, wherein pain and bruxism, tachycardia, and rumen stasis can be observed. We can see distension of the right abdominal cavity, the expulsion of dark and mucoid feces, and absence of feces in the rectum. The approach is through a right flank laparotomy while the animal is standing. In doing the laparotomy, examine the associated parts of the abdominal cavity, such as 1, omasum, 2, abomasum, 3, omentum, 4, rumen, and 5, aorta. Then determine if torsion is present or not. Correct the torsion as shown in the picture. Then bring the free part of the cecum out of the incision and hold in a ventral position. The cecal apex is incised to release the ingesta. An intestinal clamp is then placed proximal to the incision, and the incision is closed using Schmiden inverting suture oversewn with 1 or 2 continuous Lambert suture. Flash the surface of the cecal apex with saline and put it back inside the abdomen. Close the laparotomy wound as that of the right flank laparotomy procedure. Now, this ends the second part of the abdominal surgeries and ruminants. Thank you for attending this session.